Cancer is a growing concern in Nigeria, with an estimated 100,000 new cases diagnosed each year. Nigeria's Cancer Control Program and Plan through the Federal Ministry of Health since the year 2018 to 2022 and beyond reported that cancer is responsible for 72,000 deaths in Nigeria every year, with an estimated 102,000 new cases of cancer annually. According to medical experts, the most common types of cancer in Nigeria include breast, cervical, and prostate cancer. And the question many ask is, why is it claiming so many lives in Nigeria? Health records in the country indicate limited access to healthcare services, lack of awareness about cancer prevention and early detection, cultural beliefs which may lead to late diagnosis, inadequate screening programs, and challenges in accessing proper treatment and care are the major reasons why. It is crucial to promote education about the importance of cancer screening, lifestyle modifications to reduce cancer risk, and improving access to affordable and quality healthcare services in order to reduce the impact of cancer-related ailments in the country. In addition, early detection and timely treatment are also key in improving outcomes for cancer patients. This is why the federal government is committed to providing access to affordable and quality cancer treatment and care for all Nigerians. But challenges abound regardless. Many are of the opinion that given the necessary attention, there is hope for those affected by cancer in Nigeria. On Good Morning Nigeria today, guests will discuss the prevalence of cancer in Nigeria, the concerted effort to strengthen cancer prevention, treatment and care, as well as reducing the burden of cancer by improving the quality of life for those affected by this devastating disease.
Many thanks, Ibrahim, for the background report, and seated already with us in the studio to discuss the topic as regards cancer care is Dr. Mutiu Jimo, consultant radiation and clinical oncologist from the University College Hospital, Ibadan. Many thanks for joining us, Doctor.
Thank you very much.
All right, we also have here Dr. Evaritus Obo, a consultant radiation and clinical oncologist from the University of Benin Teaching Hospital, Edo State. Good to have you.
Thanks for having me.
Welcome.
We also have in our studio here Professor Usman Malami Aliyu, is the Director General, National Institute for Cancer Research and Treatment. Thank you for joining us, Prof.
Good morning. Thank you for having me.
Also, we have our Zoom guest that will join us later in the course of the program is Dr. Adeoluwa Adeniji, Chief Medical Director, Micure Cancer, will join us later in the conversation. Now let's kickstart the conversation with the DG National Institute for Cancer Research and Treatment, Professor Usman. Cancer is the dreaded disease, just like it's been reported, and the cases that we have heard are just too many, especially here in Nigeria. So, what can you give us the status of Nigeria as regard cancer, now?
All right. So, thank you very much for that. Currently, what we have, as I used to say, is an estimation of the general burden of cancer in the country, which is done by an agency of the WHO, which we call Globocan survey. So, and the estimation based on the 2020 survey that was done is annually we have there about 120 to 140 new cases of cancer annually in Nigeria. This is just an estimate generally from depending on where the study has been carried out, and it was also estimated that annually about 74,000 of the new cases diagnosed die because of the disease.
Wow.
Yeah. So yes, globally, if we look in 2020, the estimation was there about 90 million that was recorded actually in 2020, and
Globally,
90
90 million.
in 2020,
90 million.
and 10 million of death was recorded. So in 2020 the estimation was that 19 million new cases and then 10 million deaths. So more than half of, virtually, if you look at that figure, died from the scourge of cancer. Estimation by a renowned professor known as Pekin, he estimated that the incidence of this disease is going to continue to rise. So he made a clarion call to all the nations in the world that something has to be done, because what we are seeing now, in the next like 2 decades to come, this scourge is going to double. Yes, it's going to double. And what is more saddening is that more than half of this increment is going to come from the low and middle income countries, of which Nigeria is one of them. So it's like we are facing a war coming. So all the countries, he made a call that all the countries, and preferably those in the low and middle income countries, should step up and start coming up with programs and activities that will combat the menace, that will start making way and putting all the check and balances that are needed to combat the scourge of this disease. But we are happy, as I always used to say, the government of the day has heard the call and have taken a drastic action by establishing an institute, the National Institute for Cancer Research and Treatment, that is purely for cancer control, just like we have NACA and NCDC. So that is the institute that we have, an agency that is well focused for cancer prevention, cancer treatment, cancer research, and in general cancer control in Nigeria. So we have to thank His Excellency Ahmed Bola Tinubu for this very good initiative, and for the 2 good ministers that we have that are putting all their best in ensuring that the agency has operated without any hindrance, without any unnecessary interference.
All right. Many thanks, Professor Liu, for your opening comments there. Of course, you have increased the scare because, you know, you said low and medium income countries, of course, are at risk, and that's, you know, looking at the figures, already scary at the moment, and that's going to double. So I'd like to ask Dr. Mutiu, at the moment, it's still, let's say, it's still minimal, you know, the incidences, but this is going to increase. But where are we at the moment as regards care and treatment? You know, our health system, how effective is it at the moment in managing you know, cancer patients?
Yeah, thank you very much for this opportunity to talk. Like my DG rightly said, the government is doing their best, right? Unlike before, that we don't have centers handling this cancer treatment. But we have more numbers now that handle this cancer treatment. Even in addition to that, government is doing what we call Cancer Aid Fund to assist people that cannot financially capable to access this treatment, which is a good news. Some can afford it. Some people that cannot afford it, especially they target breast cancer, cervical cancer, and prostate cancer. Right? So that if someone can apply, once they registered, they make diagnosis, and then they can apply for this cancer, they will get the funding, and they can have access to the treatment. So numbers of centers that are treating cancers are more now compared to before.
Okay.
So it will be very easy for our people to just go to the hospital, right, and access this care. So it's a different news, unlike before that we have low numbers of centers, but we have more numbers, and more are still coming. Governments are doing their best to make sure that they provide infrastructure for more centers, so that every region will have access, people will have access to cancer treatment. So it has improved. And in addition to that improvement in terms of infrastructure, even financial capability for people that cannot afford it.
It's now free?
No, for 3 cancers that I mentioned now, the support.
Okay.
So that's what I call Cancer Aid Fund.
Okay.
Prostate cancer, cervical cancer, and breast cancer.
Okay.
So people, if they are aware, they come to the hospital and they register and they apply for this cancer aid fund. That's what I'm saying, in support of the infrastructure government are doing. We also have individuals that also established a cancer center. We call them private centers, in support of what government is doing. So to make sure that people can access this treatment. So it's a different news now compared to before. Things has improved, but we want more improvement. And the more are still coming from the government side. And even some private organizations too are also trying to establish, because they know we need these treatment centers.
Okay.
Thank you.
Okay, thank you, Dr. Mutiu, for your thoughts there. But what you have just said is that there is improvement in the treatment, and also the government has provided more centers, for the treatment of cancers. But from what the DG said now, which is a bit scary, that there is likelihood to be an increase in the number of cancer cases, especially in this climate, this part of the world. So let's go to Dr. Obor now. So what do you think is responsible for this increase that is being, that they were likely to have? What do you think is responsible, despite all the efforts that is being put in place by the federal government to tackle this challenge?
Okay, thank you very much. Thank you also for having me. The government, as been said rightly, has done a lot in the area of bridging the gaps. There are so many gaps in cancer care, and these gaps actually have been, made worse over time by lack of infrastructure for diagnosis, screening, and treatment. Looking at cancer, I must understand that in preventing cancer, I must look at those 3 key values. Okay. Looking at primary prevention, secondary prevention, tertiary prevention. What's primary prevention? Looking at creating awareness, cancer advocacy and cancer education. But I will tell you, it's still very poor in our climate. People still don't understand what cancer is all about, the common symptoms. So oftentimes, they present very, very late, in very advanced stage. And at that point, at best, can afford them what we call just palliative treatment. I will tell you, over 70% of patients come to us in stage 3 and stage 4 stages. This actually what we have in most Western countries, where they come much early. Why? Because they have infrastructure for screening, diagnosis, and treatment. Let's take the issue of pediatric tumors, for instance. If you have 10 patients diagnosed of cancer of the pediatric tumor, childhood cancer in Western countries, 10 of that 10, 2 would die, 8 will survive. But in our climate, like Jerry said, low-income countries like us, the reverse is the case. 8 will die, 2 will survive. Look at the burden, telling you that lack of infrastructure for screening, diagnosis, treatment has actually created so much gap in cancer care. Then also must emphasize on secondary screening. Very important. Secondary prevention looks at screening. If you screen, what you go to achieve is what? When you screen, you get cancer at an early stage, you cannot commence radical treatment aim of cure. So that will do over abroad in most other developed climes, because they get this cancer at early stages where they can have all the treatment that you may have. They can have surgery, chemo, radio. You cannot achieve cure for those kind of patients. But over here, most of the time, they always come in advanced. So coming an advanced stage is a big...
Why do you think that the patients actually come at the advanced stage?
Yes.
Why?
One of the reasons is poor awareness. That's why I said they are not so educated by cancer, and also finance. People normally face a lot of financial toxicity. They don't have the money, and they have this myth about cancer. You understand? So to a large extent, the fact that, and also we have this 30 people go to churches, they go to other people to
cultural beliefs,
understand. So to a large extent, they are misinformed.
Village people.
But then they are coming to us, they see cancer as a witchcraft, spiritual attack, and certain myths about cancer. But they're coming to us, they've gone around the route and are coming to us in very advanced stage.
All right, I'll pause you here.
So with that, okay.
I'll pause you there. But you see, I have a different view as regards what you said. It may not really be because people, you know, have spiritual beliefs or whatever in Nigeria. Don't you think that our health system too is unhealthy at the moment? And maybe that's why we're having people present at late cases. Maybe there's misdiagnosis, underdiagnosis, you know, in the part of our health professionals. But that question is going to Dr. Adeoluwa Adeniji, the Chief Medical Director, MeCure Cancer Center. He joins us now via Zoom. Doctor, can you hear us?
I can hear you. Please go ahead. Good morning.
The conversation. So, you know, doctor is trying to say, well, it's the cultural practices, spiritual, you know, beliefs and all of that. But I tend to disagree. I think that our health system is unhealthy at the moment. I think that underdiagnosis, misdiagnosis are also some of the factors responsible for the late presentation, if you like, the death of cancer patients. What's your view?
Okay, thank you very much for that. Good morning. I want to start by saying that what you said about the misdiagnosis at the primary level is actually a real factor. They all are factors that contribute to late presentation to the hospital. So how do I mean? There are cases that individuals present to maybe to the family physician or medical doctor at the primary level. And at the end of the day, the diagnosis is delayed. It takes time to get these individuals to see a specialist to have the right diagnosis. In Nigeria, especially where everybody is being taken for malaria and typhoid.
All right, Dr. Adeniji, looks like there's a challenge with your audio connection there. We hope we can get that right. But I think Dr. Mitu Jimo wants to respond to my question.
Okay. Yeah. If I can remember what you asked about the Nigerian hospitals to maybe they are contributing to where it's not that true. What do I mean by that? Most patients, even learned, you'll be surprised, learned will come at stage 4. Maybe due to ignorance. Right. By the time they present.
Doctor, you see, before you get to stage 4, you would have presented so many symptoms that you have been treating in the hospital.
That's what I'm saying. I'm coming there.
So if it was detected as at the time you presented the headache or fever.
Yeah, where they go first matters. You understand what I'm saying? Where they go first matters. Some people believe it's an evil arrow. Instead of coming to the hospital or meet any health workers, they will go to religious leaders, they will go to their traditional leaders first. Now, this is an attack. I've seen quite a number of patients that said that, even the learned.
But Doctor, with you, can I just bring up this case of late Chief Gani Fawayimi?
Okay.
You know, he was diagnosed of cancer.
Okay.
But it was rather too late, and he complained. He said here in Nigeria, several times he went to the hospital, they never diagnosed cancer. They were diagnosing something else. And when he went to the UK, that was when they found out that it's actually what he had was cancer. He was really very angry because it was at an advanced stage. So that's exactly what she's saying, that most of the time we have wrong diagnosis here in this country. So how do we begin to correct that?
Well, the infrastructure is also very important here, and the machine, the equipment to make the right diagnosis at the right time. Because the lung C that you are talking about for Gani Fawayimi, pneumonia can simulate the same symptom like lung cancer. TB can simulate the same symptom like lung cancer. So it can be they mimic. Right, somebody with lung cancer can be diagnosed as TB. It can also happen in Western world.
So you agree that there's a gap?
How?
Now, those are the things. They mimic. They look similar. The symptom looks similar.
Okay.
Are you getting what I'm saying now? Symptom of pneumonia and TB can be symptom of lung cancer too.
Okay.
So the equipment, the agents, reagents to make diagnosis is also very, very, very important here.
Okay.
You understand what I'm saying now? So this issue of misdiagnosis, they miss it in Nigeria. They miss somebody else. No, Dora Akuyuli was diagnosed in Nigeria, was missed in the US.
So it could happen anywhere.
So it could happen due to reagent, due to the machine, it could be machine error, it could be reagent error. You understand what I'm putting across? So she was diagnosed here, and the disease was also missed in the US.
Okay. There's also this case of, let me come to the DG now. The case of lack of research and data, that there is a lack of comprehensive cancer data and research in Nigeria, which limits the development of evidence-based cancer prevention and treatment in the country. What is the government doing about that?
Okay, so thank you very much for the question. Just like you have said, there has been that of data for quite a very long time in the country. But with the establishment of this institute, all the activities of cancer registry, that's the National Cancer Registry in Nigeria, is under my institute now. And I'll be happy to say just 2 weeks back, we actually had a meeting, what we call Cancer Registry Dialogue. Okay. We invited all the regional directors of cancer registries in the country, the CMDs, chairman committees of CMDs, and the big shots in the area of cancer registry in Africa and even in the world. So the African Cancer Registry Network and the International Association for Research on Cancer, the IAC, they were all invited in that meeting. So the meeting was, how can we resuscitate and revamp the existing cancer registries that we have in Nigeria. So the dialogue went on, and the black and white paper that we were able to got out of that, we have even started working on that, because we realized that for quite a very long time the government wasn't in charge of the activities of cancer registry. It was owned by actually an individual. He was the one that was managing the whole activities of cancer registry, data collection for Nigeria. And he was doing that because he got a grant from a university outside the shore in the Western countries. And all that he was doing for the cancer registries in Nigeria was through this grant. And remember, a grant has a timeline. It has a time frame. So this is very funny. When we were having that meeting, dialogue meeting, now somebody asked a question that we need to actually go back to the website of the Nigerian Cancer Registry so that we can see what, yes, that it has been dormant for quite a very a long time. No additional. I said, okay, let's log and see, so that what we are doing now, we can have a clear evidence of what we are seeing, so that behold, when we clicked, it has been crashed. So one of the directors called, and then he found out that the guy that was manning the whole website or platform for cancer registry said he, as far as he's concerned, he has finished his. In fact, the research has reached its own listing, that he has gotten enough data that he is required, and it's more than 5 years now. So all he needed to do is just to publish that and close down the whole thing. I said, what? So I quickly informed the Honorable Minister of State for Health, that is Dr. Tunji Alhassan, because the institute is under him, who now communicated to the Honorable Minister for Health, Prof. Ali Pate, and they gave an immediate direction that you are the one in charge. From now on, take charge of the whole cancer registry. As I'm talking about, we have reached there about 90% of building a national platform for cancer registry in Nigeria. Okay. And we have it for the first time in our budget. a budget line to resuscitate and revamp the cancer registries in virtually all the hospitals. So we even had a meeting just 2 days back with the IAC. This is a WHO organization that is in charge of controlling data generally in the country. And we have their full support to train our cancer registry director and assist the institute at Nigeria in building and maintaining the cancer registry. Currently, we are planning to establish a centralized pool for cancer registry. It's happening for the first time, where all the other centers, cancer registry can network and pool, so that we can have a dashboard and be able to see the cancer incidence correctly, whether it's going up or it's going down.
Yeah, of course, how effective the institute is
yes.
in dealing with its mandate. Beautiful, Professor Aliyu, but I want to stay with you. You have mentioned that, the government is trying to scale up infrastructure. Dr. Matthew has argued that, reagents, may be faulty in the US and also faulty in Nigeria, and all of that. But I want to talk about professionals now in the field of cancer care and treatment. At the moment, there's this report that says we have just about 70 consultants, radiation and clinical oncologists. You can correct me if that's not the right figure. Just about 70. And they're looking at the figures you've mentioned, those who have cancer in the country at the moment. This 70 is, I'm sure you know where I'm going to. So, I mean, how do we scale up in terms of professionals on the field, and then ensuring that even the professionals we have at the moment have the required skill to meet up with the present realities?
So unfortunately, this affects virtually not only the oncology aspect, the oncology doctors. It cut across virtually every other specialty because of the JAPA syndrome that you have been hearing about. But still, we have to still thank the government, because just last month, His Excellency Ahmed Bola Tinubu gave the directive to the the coordinating minister for health and social welfare property, that he should increase the number of doctors that we are graduating from, I think, by 100%. Yes, by 100%. And that implementation has started taking effect. Currently, the recruitment of more doctors. Those that left, he has given an immediate order to replace them. And the waiver, the Federal Ministry of Health has been given the power now to give waivers for virtually all recruitment, just to facilitate and ease the process of recruiting new hands in the country. Don't forget that training a specialist in the field of oncology is not cheap anywhere in the world. In fact, if you look, it's the cheapest in the country. And the ones we have are among the best in the country. That is why the people abroad are pulling them. The Western world are poaching.
So how do we discourage this syndrome of JAPA? I mean, because we have inadequate manpower, and they are JAPAing. So what do we do to discourage that?
So currently, part of the things that the government is doing is to improve the condition of services in the country. If you look currently, just like what Dr. Jimo said, there was a time in this country that only one linear accelerator machine was serving the whole population of 180 million then, if I can remember. And it was, I think, National Hospital. Yes, Sokoto too, yes, because we were having 4. And during Obasanjo regime, we were having 4 brand Linux through the VAMED program. And at any single time there was never a time that you can find 2 machines working. Virtually.
How many do we have now?
We have 15.
How many are working?
So we have there about 7, 8 working at a time. Yeah, so that is an improvement. So we continue to improve from that time, and during the last regime, I know we have added to the number of machines. There were 2 new centers came into existence, I think, and private center. But currently, I'm happy to announce to you that His Excellency Ahmed Bola Tinubu has given the approval to add 6 more.
Okay.
6 more cancer treatment machines to cutting across virtually all the regions in the country. And not only this radiotherapy machine, he has already approved the provision of other key diagnostic equipments to virtually additional 8 to 10 centers through NSIA partnership program. And that currently, I think even yesterday, if you attended the ministerial briefing, Prof. Pate, the minister, coordinating minister for health, he mentioned that. So I think we are, for the first time, probably, the country is getting it right. Bearing in mind that this government is only there, it's less than a year. So, but we are starting with 6. So you never can tell, maybe by next year, what will happen, because we will continue to add. At the Institute currently, we have looked into what is happening currently in the area of prevention. Treatment of cancer is quite expensive, and the best way to mitigate the scourge and catch it early is through preventive services.
Okay.
We are currently trying to launch, because we have that approval also from the federal the coordinating minister of health, to establish screening centers in the 6 geopolitical regions. So the institute is going to pick virtually 1 tertiary hospital and equip and get a clinic, what we call a prevention clinic. Before now, people have been clamoring, calling that, go for screening, go and do your screening. Where will you go and do the screening? So it is for the first time that we're going to have a clinic in each zone of the country where an individual, a client, can walk in and have screening of all the panels of cancers that he wants in the country. That is currently ongoing, and is under my agency.
Okay, all right. Thank you very much, Prof, for giving us details of what government is doing, at least to improve the care of cancer. We understand that Dr. Adeoluwa audio is better now. Dr. Adeoluwa, can you confirm that? The audio is okay now. Okay. If your audio is better now, and I understand, I want to believe that you have been following the discussion in the studio here, talking about the cancer prevalence in the country and some of the challenges that are being faced here. So I want you to speak to the issue of inequalities in cancer care in Nigeria. Are there sufficient screening facilities in the country right now? Do you think?
So concerning Nigeria, obviously, as we all know, and the truth of the matter is there are places in the country that do not have access to comprehensive cancer care. Number one reason is that it is not all the states in the country that have access to oncologists. For example, we know that there are few states in Nigeria where you have trained professionals that are called radiation and oncologists, who are supposed to supervise and provide professional and comprehensive care by working together with the other professionals. We don't have such oncologists in many states in Nigeria. If you come to states like Lagos, you have a number of them. You go to Oyo, a number of them. Then we go to Abuja, we have them in Enugu and a few other places. But as we speak, at the moment. I can tell you that, when you go to Rivers, you're going to have just one of them to take care of the entire people in that state. And that is going to be a lot of problems as it were. And there are many states that don't even have a single oncologist. So that is number one reason why there will be inequality in cancer care. Number two inequality is in terms of the available infrastructures there. We have comprehensive cancer care in Nigeria. But I must say this at this point, Nigeria is, in terms of cancer care, is not getting worse. It's actually getting better. In the last 4 years, things have happened. So much improvement have, taking place. I saw it right in front of me. In front of my face, number of radiation therapy coming in with modern structure, modern care, and facilities to take care of people. So it has improved significantly. Then another reason why we have inequality is cost. It is not everyone that can afford cancer care. Cancer care all around is quite expensive. It's, to establish comprehensive cancer care, it's quite expensive. The capital is huge. As a result of that, so a number of these, there are a number of people that cannot afford it because health insurance companies and people are still doing out of pocket,
All right, Dr. Adeniji, sorry about that. The audio connection is still not too tidy. Yeah. We hope that can be fixed. Maybe you could alter your network connection. There's been an issue with networks.
Yeah. All right, well, let's come back to this studio, Dr. Obo.
Yeah, Dr. Obo. Coming back to you, Dr. Adeniji was trying to make a point about the cost of managing cancer. You did mention, as being one of the factors responsible for the number of deaths experienced. As a medical practitioner, and then you get to see cases and patients. What really can be done in that regard? Because, like you already said, Nigeria, we're a praying nation, and nobody prays to have cancer, and then somehow it comes down, and you do not have the funds. What could be done? DG was trying to talk about a fund. And all of that, but we know that not all Nigerians can access that fund. What could be done in that regard, really? What can NHIs play a role? What can individuals do? What can government do?
Thank you. Like rightly mentioned by DG, cancer treatment is quite expensive. It's very expensive, Even the process of diagnosis, screening, and treatment are quite expensive. And usually, looking at our patients that come for cancer treatment oftentimes, quite a number of them are indigent. They don't have the resources for treatment. That can also be the reason why they want to come to the very first place and seek for other, maybe cheaper means of treatment, which leads to progression and probably come to us at a very advanced stage.
When you say indigent, some people think that cancer is a disease for the rich. That's not true.
It's not true. It's not true. Anybody can. It cuts across ages and status. It doesn't matter. I have patients that have 1 year old, they have cancer. 8 years old can have cancer. Also the rich and poor, everybody can have cancer. It's not for the poor only, it's for the rich. So it's for everybody. Everybody can have cancer. So looking at actually this cost, I'll tell you that in our experience, most patients that have cancer oftentimes definitely will have at a point have chemotherapy, surgery, radiotherapy. The average cost of surgery for most patients runs from around, for government facilities, maybe around 150 to 250. That will cost more in private facilities. Then looking at chemotherapy, it's actually what most of our patients actually have to take. Why? Because they come oftentimes in advanced stage requiring chemotherapy, systemic therapy. So in doing that, what's the cost? Chemo ranges from an average of 150 to about 200, depends on the chemo you are giving. And also, if you have to progress to higher therapies, which you call immunotherapies, those cost far more. Looking at maybe around 700, a million, and even more for each course of chemotherapy. Then the therapy now for, like the gentleman, we have private centers and government centers. In private centers, the average therapy cost for patient for breast cancer is around 1 million to 1.2 million. Then for government, it's about 800 to 1 million. So that is still too high for the average Nigerian. Here in our country, like Dr. Delmer, they pay from their pockets, unlike in Western countries, where they have a very functional health insurance. But over here, attempts have been made to actually incorporate it into the health insurance, the Nigeria health insurance. That is still being perfected, but I can assure you that cancer treatment is not wholly taken care of by health insurance. But some molecules you have in cancer treatment, some are taken care of partially, not completely. They pay a percentage, making cheaper. But what companies are actually in Nigeria health insurance? That's an issue. So it's still mainly for the civil servants, those who are working, maybe in corporate bodies. But those who are doing business, how well are they represented in the national insurance? So they are cut off. Then for the cancer health fund, it's eligible period by Federal Ministry of Health, where we have cancer of the cervix, cancer of the breast and prostate taken care of. They get a first tranche of #1 million, another #1 million, making #2 million. So it pays for everything from surgery, chemo, and even radiotherapy. To a large extent, it's been availed of to many patients and even utilized maximally. But not all centers actually are involved in this study. So, but hopefully, like DJ said, there'll be second phase. It will be more cancers beyond just prostate, cervical, and breast, and also more centers. Now they just that involved, only for are involved, and with the next center, hoping that we'll have start involved and expand the scope of cancer that will be involved as well. Looking at what we can do in this area, what I believe is that we have to get government to do more. No doubt they've done a lot, but they still have a lot to do. Like I will tell you now, Nigeria has 14 machines, 8 working, but what's the expectation? Going by the high regulation, you should have about 200 machines, because it says that you have 1 megawatt machine to 1 million population, and we have 220 million, and we're having 9 machines working, 8 machines working. It's still very much below expectation. So some cities in the UK can have as much as even 10 machines, 9 machines. So Radley said, we've done well, like in 2015-16, like Radley said, Edasoto is working today, or Benin is working the other month, or Abuja is working. It kept happening that way. So people now adopted migratory pattern. What do I mean by that? Oh, Benin is working now, let's all go to Benin. Then after a time, Benin has a problem. Oh, Sokoto is working. Oh, we all now migrate to Sokoto. You know, it was like migration pattern of getting care for patients. Oh, Abuja is working now, everybody moves to Abuja. You know what that means? These machines have their own limit. Yeah. They should not treat more than 40, 50 patients. They're taking 150. That's a red flag for us. But you can't stop at that point, because where would they go to? So because of that, it affected Sokoto. Sokoto actually broke down. Benin had something. Benin broke down. Abuja broke down. And like you rightly said, this initiative by government is very laudable, highly commendable, because we're not seeing the lights. Why? For the very first time, we're having 14 centers in Nigeria and 8 or 9 working, and we're not getting more private people involved in care. What I'll say is that let's get more people into the more of cancer treatment into the national cancer, national insurance, health insurance one, and also expand the scope of cancer health fund. Let people now also try and also know that apart from cervical, breast, and prostate, you can have in the colon cancer, head and neck cancers, and that cancer that naturally just is 3. So lastly, my answer would be that we can also, apart from having more centers, if you have more centers, government can also create more like a fund to also, apart from the cancer health fund. Like you go to India, they'll have what they call for their own citizens, an indigent fund for them. They pay less. That happens. So that's why we have cancer health fund. We can do more of that too. And also discount the cost of this cancer care. Because the continuum of cancer treatment is both taught to the patient financially and treatment-wise. So because of that, I think government can do more. And also you can go to the tiers. What prevents states from having a machine? States can have machines. So it's going to be left with federal government alone. We can get states having their machines. If you have federal having their machines, you have that machines. Of course, we're going to have more centers. And of course, the cost will go down, government intervention. Now becomes more affordable and available. Okay. People can now access care of cancer and have better outcome. Right now, the outcome is still very far from what we actually want to achieve. Nigeria deserves more. Okay. Like I was in Tanzania, and that was some time ago for a training program, and retirement in Tanzania is free. Once you diagnose you are having retirement free. Because what the government actually is doing. They give the center enough funds to take care of that. Nigeria can do that as well. We have the funds. So I'll commend the present government, and I think they've done enough, but they've done well, but they can do more in that area. People are still having poor outcome, people are still dying from cancer, avoidable deaths, because they are coming advanced and they cannot afford treatment. Okay. So I think our government to do more, like they're doing the right, like Charlie said, establishing more centers involving cancer health fund. Cancer health fund should also be expand to involve other cancers and also other centers as well.
Thank you very much, Dr. Obo, for providing solutions to some of the issues that you have raised there, which is, and I think the government is listening, and I think that they will do the right thing. Let's move to Dr. Mutiu Jimoh now, because some of the issues that he raised earlier is the issue of stigmatization, cultural beliefs, and how do we begin to overcome, these challenges? Because most times, just like he said, people will go to churches instead of going straight to the hospital to first, make the complaint. And before they realize it, maybe it's not working, they now go to the hospital and they now discover that it has gotten to the 4th stage or the 5th stage. So how do we begin to, begin to change people's orientation?
Thank you very much. Is a part of awareness is what we are doing here. Creating awareness, educating people that cancer is not a stigmatized disease. It's not a death sentence. Right. It's because people come late. That's what causes problem. So we need to educate people not only in schools. We go to religious places, we go to community to educate people. People need education. People need counseling. They need to know that cancer is a non-communicable disease, but it's not a death sentence, it's not a stigmatized one. People believe once you have cancer, you are abandoned. No. So education, counseling is key. Not only, like I said, not only in schools, but we'll go reach out to the community, reach out to the religious leaders, during the church service, during the Muslim Islamic services. We need to also bring in maybe 5 minutes or 10 minutes to talk about it. People need to hear and hear over here. Apart from mass media, radio, TV, television, news, social media, apart from that, we still need to go to enter the communities, enter the church leaders, talk to people, because they need to tell our people. They need to know. I said it, that learned fellow, ignorance. Ignorance. Somebody who is a learned come in stage 4, you'll be surprised. So education, counseling, and our people need to also change their attitude to listening to all this awareness when we are creating it. Listen to news. When they want to talk about health education, people need to create time to listen. It's very important. People they ignore it. If it's another thing entirely, they will listen to that one. But health education is key, so that we know we can change our lifestyles. So we have to improve.
What about our diet?
Yes, diet. There are some cancers that diet are very implicated. We talk about processed food. We encourage people to take more of normal diet. Stay away from processed food. The book says processed food, do it in moderation.
When you say processed food, can you just...
Well, we are talking about something smoked food, all this refined food, So, and those are the ones that are implicated. So that people should do it in moderation. If you cannot afford it, they do it in moderation. And do more of fruit and vegetables, exercise, to change our lifestyle. There's no reason for Africans to smoke or take alcohol. No reason.
Okay, Dr. Jimoh.
That's contestable. But you see, the thing,
because there's a percentage that if you stop smoking or alcohol,
yes,
there's a reduction.
Okay.
There's a reduction.
Okay.
Because we know that smoking and alcohol are implicated in almost all cancers.
But this problem, there's these high costs, in food now, especially what is called vegetables, fruits, and all that. And then people are complaining seriously that they can hardly afford to, buy such. In this situation that we are in right now, how would you advise?
Thank you very much.
What would you tell
You are
Nigerians?
talking about cost of fruits. There are some vegetables that you can just grow in your compound.
Okay.
Water leaf, bitter leaf, these are the part of what we are talking about. This issue of costing is not only limited to Nigeria alone. People are just making noise. Abroad is more.
It's global.
Yes, it's a global thing. So the little one that we can afford, we go for it. Cucumber, garden egg, they are cheaper ones.
All right, thank you, Dr. Jim. And that's the direction the First Lady is actually looking at, home gardening.
Home gardening.
People having to plant certain things in their homes. But away from nutrition and diet and how we could be able to, prevent ourselves from getting cancer. Dr. Aliyu, I'd like to get to you now. And because you mentioned prevention earlier, that is key. If Nigeria can get that right, I think that care and treatment will just be something we can wave off with our hands. For example, cervical cancer. A report says that 99% of 99% of cervical cancer is actually preventable, and is the second leading cause of death. So, I mean, you just place it. It's preventable, but yet second leading cause of death. So it means that something is wrong as regards prevention. Now, what can we do in that regards? And then you talked about scaling up infrastructure, but I'm wondering, a lot of Nigerians do not have access to secondary or tertiary health institutions in this country. I tried to mention that our health system is unhealthy earlier, and that's because a lot of people, majority of Nigerians have access to primary health care. Do we have cancer, is there anything that has to do, because when I talked about misdiagnosis and underdiagnosis, it starts from there. You have a headache, you go to the primary health care. They don't know anything about cancer there. All they have is probably someone who just did a small teaching practice in nursing, who knows nothing about cancer, and then you keep going there for 1 year, 2 years, and then so what are you doing to ensure that it's not just in the secondary or tertiary institutions that you have cancer treatment and detection? It trickles down.
No. So thank you very much. Maybe let me start with that. It's a very good question, actually. At the Institute, under the Directorate of Cancer Prevention and Control, we have actually outlined the activities that we're going to do in this year 2024. We have launched our 5-year strategic cancer control plan for the country. A review of that of the 2018 to 2022. We have reviewed, we have a more recent one now for 5 years going up to the year 2027. So it's a part of the activities that we are planning to do in this 2024 in that department is to upscale the activities of cancer prevention activities. And the first thing we did was we have recognized that, and I actually don't know whether you maybe you must have gone through our act. That was why you are bringing that. One of the things is that the institute is expected to actually establish or manage or run a kind of cancer preventive services in all the primary healthcare services within the country. So when the new executive director of the National Primary Healthcare Development Agency was appointed, Dr. Mui Aina.
Prof, just a moment.
Okay.
We'll need to go for a break now. When we come back, we'll continue from where you stop. We'll take a break now. The conversation continues. Stay with us. You're welcome back. You're still on to Good Morning Nigeria, and we are still on the conversation, the treatment and prevention of cancer in Nigeria. Before we went on break, Prof, the DG, was speaking on Larry's question, that is making the treatment of cancer available at the primary care levels. Can you just continue?
All right, so thank you very much. So there about a month ago, also under the directive of the coordinating minister for health, we had a meeting with the executive director of the National Primary Healthcare Development Agency, a closed door meeting actually, and one of the key things that we have discussed is how can we establish screening for the 5 common cancers in Nigeria within our primary healthcare services. And part of arising from that discussion, currently we have actually established like a committee consisting of those from the National Primary Healthcare and the NICRAT, the National Institute for Cancer Research and Treatment. So we are currently working on that because what we have, the caliber of the healthcare workers that we have there are either nurses or CHU, community health extension workers. What we intend doing is to train them on virtually how to give awareness on cancer education, the common cancers, so that maybe during the routine antenna ANC clinic and some other activities, they were able to educate the community on the signs and symptoms and the risk factors of common cancer, and then teach them to be able to carry out simple examination like breast self-examination, which is known to have actually saved a lot of life, because it makes the detection of breast cancer very early, and at that stage that it can be cured. So when we establish that and train them on how to do breast self-examination, a simple pap smear, and to also link those primary healthcare center to a nearby oncology center, that is an establishment of a standard referral system, which they already have. But this time around for cancer, we want to strengthen that. So if we do that, definitely we know there is going to be remarkable improvement in the number of early presentations in the country, and a lot of people can be saved. So we have been doing that. Why we decided to actually start this preventive clinic services is because initially we wanted to say, okay, let's start with the primary healthcare, and then secondary, and then the tertiary. But just like you rightly said, we now look at now, if you now plan to take these gadgets to the remote areas, they don't have the enough manpower that is required to man the process. Sometimes if light could be an issue. So what we said is, before now, we don't have any screening clinics in the hospitals. There is no hospital that you can walk and said, okay, I want to get myself screened, and then you can get, maybe you can start, people will be testing you, okay, which type of screening, or you want to do pap smear, you have to go to the gynae. Is it breast self-examination or breast? You have to go to either an oncologist or department of surgery. So we want to actually establish a one-stop shop clinic for screening services, where from there you can have a health education program on all cancers, the risk factors, the common signs, and how can you prevent yourself. If you need these screening services, you have them here. Within the doctor there will see you and recommend and give you a paper where you can go, and so that it makes it easy. You know?
Talking about making it easy, are there alternative, or if you like traditional, forms of cancer treatment?
Alternative?
Yes.
Yes, there are a lot. And when Dr. Jimmy was answering his question, I was just laughing. When I was in Sokoto, when I was fully in the clinical practice, for my master's degree, I conducted, there is one study that I conducted, and currently that paper is I mean, a lot of people have been asking to get the paper, is the use of complementary and alternative medicine among cancer patients. So the prevalence that I got was quite shocking. More than 60% of all the patients, more than 60%, their first point of call was this complementary. And this complementary could either be what the traditional house, the prayer house that we have, the chiropody, different types, we have them different types. So usually our people, we still have a very long way to go in the area of awareness to enlighten people more. They believe, and the attachment that people have with their religion is actually a no-go area. Because even if you start to I mean, a kind of advise people on, you know, this thing that you have. No, my brother, it's God. Oh. Even if I come to the hospital and take the medication, well, it's God that heals. So we have that, and that can be taken away from us. But what he rightly said is, we have to have a way of engaging the prayer house, the community leaders, where these people go, and even the gatekeepers, because the gatekeepers plays a very important role. When we say the gatekeepers, we are referring to those people within households, within community, that people listen to, that have say.
All right. Yeah. Thank you very much, DG. There, we need to have enough contact with all these traditional rulers, religious leaders that are engaging with the communities. Let me come to Dr. Obo now, and my question will be: do we have enough support services, you know, in regards to cancer? What I mean is that do we have you know, available, you know, services that are available for cancer patients in Nigeria, such as counseling, palliative care, or survivorship program? Do we have enough?
Okay, thank you. We have no doubt. We have in Nigeria. We have, although we don't have hospice, which you are aware of, but some centers have functional palliative units, and they also have psycho-oncology clinics, and we also have some support groups for patients. I recall during our training at UCH Ibadan, we had a very functional palliative unit. Understand? Patient comes to you, and oftentimes, you know, if it's advanced case, and you understand the fact that this at best you can give palliative care. There's no plan to achieve a cure. You know, you have to make them understand that this end journey for the patient, you know, you have to carry the caregivers along, because they also are as devastated as the patient are. So you don't just really focus on the patient alone, you know. Oftentimes, they do run around, they do the patient's personal care, and they feel the pain, either as siblings, as parents, or as children to an ill patient with cancer. So they are giving good palliative, care, or end-of-life care for those patients, you know. And even the treatment too, you also have to modify your treatment to suit your palliative intent. If you're going to give some treatment, you don't want to be too aggressive, you don't want to be too radical, because at that point they respond, they get to have more toxicity, they have to have more adverse effects when they're also more advanced than even the ones that are also early and also more fit. So because of that, we have palliative care in the country, but I will tell you that most centers still don't operate a functional palliative system, just with foster centers. Then looking at the aspect of the psycho-oncology clinic is very important. We have some centers in Nigeria, but I'll tell you there are still very few centers having functional oncology clinic. What we do actually is to help the patient understand the treatment journey for cancer. It can be very traumatic, for them can be very devastating, and they don't even understand the journey. You know, it starts from you're in the clinic, you're told now you have cancer. Everything changes for you. You know,
moment you even mention that word cancer,
diagnosis, no, everything changes for you. You start asking yourself,
like a death sentence.
Yes, you start asking yourself, no, they believe that's a death sentence. And like Jim rightly said, it's not a death sentence. It's not. We've seen many people who managed for cancer that are doing very well. 10 years post-op, they're standing, working, and now counselors for other people. So what we do in my center in Benin, well, we try to bring them on. We bring survivors. They tell this patient, your journey today, I've gone through your journey. I've been there. I had surgery. Someone even came last month and told them how he was sent to Sokoto in 2015, 2016. You know, he met the doctors there and he was referred back to Benin. That was in 20, and now he's standing almost 10 years. You know, the journey can be so devastating.
Completely free from medication?
Yeah, free medication, yes. So the patient at least familiar with. So it tells you that we have to do more in the area of oncology. Like in Benin, when we do that, we tell them what are your concerns, what are your worries, what are your myths you feel about cancer, what are your worries about nutrition. Let them, they express their mind to us, and we try to allay their fears. We try to encourage them on that journey. Cancer treatment journey is an easy journey for anybody. So, and those that have gone through it, we get together and we made them tell other people how they did their navigation to the system, all the treatment points, and now they are back and they are well and strong. It gives them courage for the journey. It gives them hope and strength for the journey. Because at any point they can easily be discouraged, even by a friendly doctor. Not because of you as a patient. Maybe something happened. Because I don't have, there's no hope for me. Or maybe a nurse that may have a bad day.
Or there's a strike.
Or there's a strike, you know. So it makes them feel as if, oh, I said it, you understand? So we must claim more that my advice is that let more centers have psychology clinics.
Okay.
It's very important. It complements the conventional clinic. Okay. Here they're able to interact with doctor freely. We allay their fears, reassure them that a journey that others have gone through, and you too can also go through it and come out with a positive testament to it. So, so I think it's a good thing for us that more centers for that. Then for the support groups, we've had people that actually have been coming with support. They bring money. So in our center, we give give them refreshment in Benin. We do that for them. Okay. Yes, and it's good for them.
Okay. Do you do that in Ibadan?
We have facilities for
that. Maybe you can talk more to that.
Talking about refreshment, I know women like refreshment a lot. Yes, is that why the report that we have shows that there are more women who suffer from the cancer than men? Is cancer gender insensitive?
Has no respect for anything.
I'm quoting a figure. Okay. There's a figure from 2020 that states that estimated 78,000 Nigerians died as a result of cancer related complications, and then it says that 44,000 were females, while 34,000 were males.
You know, women compared to men come to the hospital. Men, you see the way they are making noise about breast cancer. How many prostate cancer did you hear noise about? For men, I don't know.
So they die silently.
They don't. But women will come.
Okay.
But men will just silent on the. People are making noise about breast cancer. Nobody is talking about prostate cancer.
Prostate cancer. They do talk about it, but maybe not as much.
As much as breast. So for women will come. But men, I don't know. We don't know for no reason that people just silent.
That's our package. That's how we are packaged.
So do you understand what I'm saying? So those are the things. And cancer, like we are saying, has no respect for age or your social status or your race, or your education.
So how do we encourage the men to now come out? How do we educate them? How do we encourage them?
We continue to make noise through mass, media, communities, religious leaders, to tell people that they need to come out once they see any changes in their body. You don't need to wait. You need to visit hospital. Like DG said, primary area, and then if we have a screening package there, they can link them to secondary institution, tertiary institution, from there. Because screening is cheaper compared to want to manage the disease. And when you pick a disease at the screening level, you can equally eradicate it or cure it than when it is not symptomatic. Because screening means you are just taking people that are healthy, you want to check, So we need to continue to make noise, create awareness that men too need to come out as women are coming out. Because prostate cancer is the leading in men, while we have breast in women.
Beyond making the noise for people to come out for screening, also making it readily accessible is also key, because I remember when HIV was an issue. I mean, when you get into the hospital, that's like the first thing they do.
Yes.
All right, everywhere you go. In fact, they come to the markets. They come everywhere. And so people got involved, and then people got to know their status. So for cancer, if you have that kind of awareness, and of course you match it with that kind of action, of course a lot of people will get tested, or if you like, get screened, and they would know their status. But talking about how we could solve this problem, Professor Aliyu. We've talked so much about this disease. If people come out for screening and you get them screened and then they have cancer, another block, we already mentioned it, but I want you to tell us what government is planning to do or is doing at the moment, is that issue of funding. I mean, you don't save to treat a disease. And then sometimes, looking at the present economic realities, people cannot even raise the money whichever way. He talked about a particular country that cancer treatment is completely free. What is government planning to do? Just so that we can reduce the cost reasonably and it can be, affordable and, if you like, completely free.
All right. So, thank you very much. He actually started tackling the question, but let me add to what he actually said. Some component, it's amazed you to know that some component of cancer treatment which cut across surgery, even the diagnosis and chemotherapy, are covered by NHIS. The problem we have with NHIS is coverage. What is the percentage of even those that are not suffering from cancer, are covered by NHIS? And that is what currently the coordinating minister for health and the new DG of the NHI, Kelechi, are working to actually drastically improve the coverage so that at least we can have more Nigerians under that. For long, we are stocked around there about 5 to 7%, which actually is not telling good of me. If you go to Tanzania, where he mentioned, you can see 80 or even 90% of the populace. Healthcare financing is actually not free anywhere in the world, so the country must come in. And I'm happy currently, I think during the media briefing, there is, I think within the span of just this 8 years, we have there about 800,000 increment in the number of recruitment, and it continues to go up because the Honorable Minister for Health and the DG, they are currently mapping out a strategy, a better way of taking it to a remarkable number that the Nigerian will actually get. So some form of cancer care are being covered by NHIS. Okay. The only problem is coverage. We had a series of meetings some few months back with the DG, and what we are trying to do is to bring radiotherapy into that, and radiotherapy too has been inculcated into it currently. So the push should be now to improve the coverage, so that at least even the people in the local community can benefit from that. He mentioned of Cancer Health Fund. It's an initiative of the federal government, and currently the Cancer Health Fund is under NICRAT. Yeah, it's being co-managed. The NICRAT is an agency of the federal government under the Federal Ministry of Health. We are co-working closely to see how we can revamp. It's supposed to say it is a contributory kind of fund, so the government will put something into it, and then the other well-meaning Nigerian, the rich and the business people within the country, can also come and donate to this indigent cancer patient, and we have already set a machinery for that on how to reach out to them.
Thank you very much, DG. Let me just because of our time now, before we round up, let me just bring in Dr. Obo now. Earlier on, he's talking about to have a wider coverage. Earlier on, you talked about the issue of collaboration between the federal and the state government in regards to level of intervention and collaboration. What should be the responsibility between the state and the federal government as regards this level of intervention and collaboration?
Yes, like I rightly mentioned, the infrastructure presently for both diagnosis treatment, they are just inadequate for the country, the populace. And then I also mentioned if I will now have private individuals having radiotherapy centers, and some are having partnership with federal government, like you have in Lutz, another center like UNTC as well. So I also believe that incorporating the states will to a large extent help to, avoid this discrepancy, in the sense that each states can have radiotherapy machines in each states. You'll be talking of having as much as over 30 machines. We need over 200 machines. So if state can, what we collaboration, one, manpower training. State may not have the manpower, but federal can help to train these people, train at a level of probably cancer diagnosis, screening and treatment. Like I said, it's very diverse. We have radiation oncologists, we have medical physicists, we have therapy radiographers, nurse oncologists, biomedical engineers. So that's why you have to have that actually makes a team to manage cancer. So it's a lot. You have to train every one of them in that area. So it means that in the area of training, government can actually help to train personnel who can actually support the state in running these services. Why they can partner in acquiring the machines. So when the states, I'm talking about, it's a lot of money for the machines, but they can also partner in sourcing and getting the funds to get the machines and in training of personnel to operate and operate the centers.
Because of time, we'll have to leave it at that point. Many thanks, Dr. Barito Zobo, consultant, radiation and clinical oncologist, University of Benin, for joining us for the conversation.
Thank you.
Of course, Dr. Matthew Jumo, consultant, radiation and clinical oncologist, University College Hospital, Ibadan. A pleasure to have you.
Thank you.
So I have two of the very few oncologists with me in the studio this morning. Great. Of course, Professor Usman Malami Aliyu, DG National Institute for Cancer Research and Treatment. A pleasure to have you again.
Yeah, it's my pleasure. Thank you
we do appreciate Dr. Adeoluwa Adeniji, Chief Medical Director of MeCure Cancer Center. Unfortunately, network couldn't help us interact properly. I'm sure some other time will present a better opportunity. Thank you so much. All right, so.
Well, this is where we draw the curtain for today's conversation. There will be more next week. Thanks for staying with us, and do have a pleasant weekend. I am Adimola Adeoye.
And I'm Henry John.